Lovely. So yeah, today it's the resource webinar focusing on the hypertension and lipids resources that we've developed at UCL Partners for CVDACTION to support the adoption of the tool and for the treatment optimization to take place in primary care. So to do that, I'm just going to do a quick recap of the dashboard to sort of show you where you might be able to find those resources yourself. And then I'll be handing over to Helen, who you can introduce yourself shortly, and we'll go through how you might be using some of those resources in a real life example, looking at a case study. So if we start with the dashboard, I'm hoping a lot of you will be very familiar with this by this point. So I might be teaching you to suck eggs slightly, but regardless, oh, I've lost everyone. Can you see the dashboard? Is that?
Yeah, we're still here,
yeah,
and we can see the dashboard.
Okay, perfect. Yeah, so as I said, hopefully you're all very familiar with this, so I won't harp on too much. I just wanted to pick out the specific elements of the help panel, which is where you'll find all of the resources that we'll be discussing today. So I've clicked onto one of the condition pages, so hypertension here, and you'll see that all of the buttons stay the same along across all of the pages. So the first one that you can click onto, sorry, it might be a bit slow. I think it's the connection I've got here today. So the first button gives you the clinical next steps guide. There's a bespoke one of these for each of the conditions, and it's sort of a quick reference guide that you can use. Either you can have it you know, in your clinical room, or while you're deciding how to interact with the cohorts that you're identifying in the dashboard. We've sort of developed it as a initial a reference point for you to consider the next clinical steps. So that's that, and as I said, there's one of those for each of the conditions. The next two buttons are information about the dashboard. So there's the second one down is a video about how dashboard works. So if you're new to it, or if it's your colleague's first time, then I would signpost them to that to get a bit better understanding about how it works. The third one down is also just understanding the processes, so it just gives a breakdown of what all of the buttons do, so I won't focus on that for too long. The next one is the links section, and this again is customized to each of the condition pages, and this is where you'll find the most salient resources for each of those. So there's the relevant NICE guidance for each of the conditions. There'll be the condition resource pack, which is it's based on the practice care framework resources that we've developed previously, but it's streamlined specifically for working on CVDACTION, and this link will take you straight to that pack. And then lastly, there'll be the sort of wider resources again that are available through the practice care frameworks, but things to support practice care consultation and education, behavior change and self-management with patients. So there's a links page on every one of the condition pages in the dashboard, and this will give you specific links related to each of those high-risk conditions. And then lastly is the list of indicator definitions, which are included in each of the dashboard pages. So we're on the hypertension page here, and it will just give you a breakdown of all of the groups that are highlighted, what the ID is, what the indicator is, and hopefully you'll find that useful to align with the sort of QoF work that you do and the other domains where you're using these indicators. So that's a short summary of the help panel. And as I said, we're now going to focus on the resources that are embedded in the dashboard, specifically around today. We're looking at the hypertension and lipids, and we're using a case study that's been pulled together to sort of showcase some of the resources and where you might want to use them along the pathway. So I'll hand over to Helen now, to introduce yourself, and then we can get going with those slides.
Thanks, Harry. I'll just see if I can make my screen share with the correct slide sets. I obviously have lost sight of you all now, so can you see that, and is it full screen?
Yeah, we've got that.
Brilliant. So yeah, we thought we'd use a case study rather than just go, and the next slide tells you how to do this, and the next slide's about that. So a case study to illustrate where you might use various parts of the pack that we put together, what might be relevant to different staff cohorts, and some of the resources that we've got in there for patients. So this is our case study. It's a very simple case study, and just really to illustrate, as I say, where the different bits might be used. So our 56-year-old bus driver with hypertension, his blood pressure is poorly controlled. When his last blood pressure was measured, he has been invited, but he hasn't responded to his cough recalls. He smokes cigarettes, prescribed amlodipine 10 daily for the past 2 years, and is not on a statin. So those two things are obviously going to flag on CVDACTION. There may be other things like he's due a cholesterol test that he needs a CKD check, for example. But specifically here, we can see already he has raised blood pressure, it's poorly controlled, and he's not on a statin. So when thinking about John, what can we do for him without physically seeing him? Would he engage better if we were doing things remotely? What do we do about lifestyle advice, and where can we access it? Does he need additional drug therapy for his blood pressure? And are there any other concerns that we should be looking at? So within the packs, we try to address all of these elements. And the starting point might be, can we get an up-to-date blood pressure? I didn't tell you when his high blood pressure was recorded. It may have been, 2 years ago if he's not engaged with the process. Excuse my coughing, it's a bit of hay fever kicking off my asthma. So we have a pathway to support home blood pressure monitoring, or blood pressure monitoring, I should say, outside of the surgery. The patient may have a blood pressure monitor. About 40 to 50% of people on the heart failure registers in England have a blood pressure monitor, and it's more common in people from Black African and Caribbean and South Asian backgrounds, interestingly. So has he got a blood pressure monitor as the starting point? If he doesn't, would he be willing to buy one so he can monitor himself? Is there a local scheme to supply one? And if we can't get a blood pressure monitor, or he declines monitoring at home, obviously there's face-to-face options, and probably the simplest from an access point of view at the moment is the community pharmacy blood pressure checks programme. So just some ideas about how you might embed monitoring that doesn't necessarily have to mean you see the patient yourself face-to-face in a practice. So the first starting point of this might be a healthcare assistant or one of the R's roles contacts the patients to do a bit of fact finding, asking about the understanding of blood pressure and cholesterol, providing some information and signposting to things like the British Heart Foundation websites, and all the links are in the packs, to support the patient with their own education, their self-management, their behaviour change. Got lots of links to videos on how to measure blood pressure accurately at home and send in the results. You might be able to then activate an Accura Explorer, which would encourage the patients to submit their blood pressure readings. Asking about smoking, and again, signposting if he's ready to quit. We've added an element of mental well-being into all of our packs, particularly post-COVID. A lot of patients were feeling isolated, so links to support if there are issues that come up there. And they might be able to help collate information to support the clinician's clinical consultation, which may follow. So just a note on the work we've done around the wider workforce. They could be a relatively wide variety of people who are working within the practice. It could be a healthcare assistants, health and wellbeing coaches, pharmacy technicians if you have them, social prescribing link workers, care coordinators, nursing associates, physicians associates, your clinical pharmacists, and your existing nursing team, but actually you might want to save them to do the prescribing interventions if they're prescribers. Even dietitians, podiatrists, OcuHealth and mental health practitioners can all help support proactive care for these patients. I'll probably miss someone off the list, so feel free to add your own depending on the workforce you have within your practice. We don't expect everyone to have everything. So in order to support those consultations, we've developed a guide for proactive care consultations, which you can download. And the aim of this is to make it comprehensive, ensure that we don't miss anything, and identify red flags which would require earlier intervention from a prescribing clinician, for example. So the practice care consultations take people through how to do a consultation and focus on, for example, in hypertension, education around what is blood pressure and what causes it, risk factors for heart and circulatory diseases, and understanding cholesterol, supporting patients with self-management, so things like top tips to reduce your blood pressure, how to check your blood pressure video, things you can link the patients to, and then lots of links to resources to support behaviour change around healthy eating, being more active, stopping smoking and drinking less. So these are all available on the website for downloading. And some of the impact of lifestyle modification, I think we often think the only thing we can do for people with high blood pressure is start medicines. In actual fact, lifestyle intervention is very effective at lowering blood pressure, probably at least as good as starting the first drug. It takes longer, obviously, particularly if we're talking about weight loss and being more active. But it is very effective, and I think it's really important that we can communicate how effective that is to patients, so it gives them, empowers them, and motivates them to want to change their lifestyle. As I said, lots of resources for patients around education and self-management, from, you know, what is AF and how can I check my pulse, to what blood pressure machine should I buy and how do I use it, to guidance on lowering cholesterol. These are just a few examples of the resources that are embedded. The links are embedded, so you can easily go to them in a consultation. And some of the more central resources from the NHS, including the 1U resources and Every Mind Matters. There we go. So if we go back to our patient, John, one of the things that the wider workforce can support is collating the right information, making sure everything's there. So it could be getting home blood pressure readings and averaging them, getting patients to weigh themselves and calculating the BMI, ensuring the right blood test results. I mean, we know he's not on a statin, so having at least some lipid results is helpful. His smoking status, current smoking status, and whether there's been any change. With that, we can then calculate a Q risk score, which will help determine whether we need to consider a statin for him. And also checking things like, well, has the patient been picking up their medicine? They're on amlodipine, they have been picking it up, but we can still see that his blood pressure is poorly controlled, he's a little bit overweight. Cholesterol feeding into the Q risk score, we end up with him being a smoker, a Q risk score of 17.5%. So he's in the range for consideration of a statin. And that then means the prescribing clinician can really focus on that medical intervention, because much of the all the other issues, lifestyle, etc., have been touched on. Although I think we should still, in all these consultations, reinforce the importance of lifestyle and just double checking that they are checking into the right person, social prescriber, health and wellbeing coach, or whoever you have locally. So prescribing clinicians should have the information they need in terms of blood pressure readings and blood results, can re-highlight those lifestyle and behaviour change issues, explore a bit more about medicines and if he's taking them. It's surprising how many people pick up their medicines but still store them in the cupboard at home. So the collection of medicines, the regular prescribing and dispensing of them doesn't necessarily equate to adherence, and you know, open questions about whether the patient is or isn't taking their medicines. Checking on the complications and comorbidities if there are any. Obviously his blood pressure is poorly controlled, so we need to adjust his medicines, and we should be starting that conversation at statins. You've just changed his blood pressure medicine, so you might not want to change something else that same day, but it can be the start of that conversation. Do you want to have a look at some resources? Do you want to have a conversation about statins? Think about it, think of the questions you want to ask, and then we can discuss it at the next appointment. So we have NICE guidance. All of our guidelines are aligned with NICE. We're not suggesting a more aggressive therapy than what NICE says. He is on amlodipine, a CCB, so the next step for him would be the addition of an ACE inhibitor or an ARB. For him, as he's Black African man, we'd probably be preferring an ARB or a thiazide-like diuretic in step 2. And then, you know, if that doesn't work, we'd be looking at the addition of a third agent in a month or so time. And time does matter. So a study by Zhu et al., which was published in 2015, showed that a delay of more than 6 weeks before intensification of medication for hypertension, or a delay of more than 12 weeks before the patient gets followed up after a change and intensification of their antihypertensive medication, was associated with an increased risk of an acute cardiovascular event or death. So often I think we think of hypertension management as a marathon, not a sprint, because, you know, it's a long-term condition they're going to live with for a long time. But we do have evidence that early control of blood pressure and early follow-up to confirm that control actually does reduce their risk of having an acute cardiovascular event or death. So important that we don't make a change and then think, well, we'll pick them up in 6 months. We should be endeavouring to follow them up as early as we can. So I'll take you through some more of the resources that support that clinical consultation in a moment. But, you know, ideally we want to ensure that John is scheduled for a follow-up in a month. If you've started an ACE or an ARB or a thiazide, it's good practice, obviously, to check their bloods, review their renal function. So that can all be scheduled at that first appointment, making sure that we're repeating the messages about lifestyle and that he's engaged with the practice team who might be able to support him more long-term with that. Address any concerns or side effects with the new medication, make sure he's taking it regularly, increase the dose if it's appropriate depending on the drug, and this would be the time, I think, to revisit statins and hopefully be able to initiate atorvastatin 20 milligram daily after a SAID decision, which would be in line with NICE guidance. So within the hypertension pathway, we do have the optimization pathway for patients requiring lipid management for primary prevention. So this would be John. He's got hypertension, he's got a high Q risk score, he's not got cardiovascular disease at the moment, so he's a prime prevention patient. We should be considering statins in anyone whose Q risk score is above 10, taking into account, can we do other things like address lifestyle and control other risk factors which might help bring it below 10. But if you're initiating statins for prime prevention, it's a pretty simple pathway. Atorva 20 or Rezuva 10 as an alternative. That's a high dose. That's a high intensity statin. NICE still recommend that we measure non-HDL cholesterol and that it should be reduced by 40% from baseline. Now, Atorva 20 on average reduces non-HDL cholesterol by about 43%, I think. I'll show you a slide in a minute that will confirm or refute that. So the vast majority of patients who start Atorva 20 will achieve that target. NICE says if they haven't, then we should consider titrating up the statin and adding ezetimibe as an option to make sure that we do get that 40% drop. But the first reason for not getting the 40% drop is usually adherence. So check that they're actually taking the meds before you start escalating therapy, because obviously they're not taking them in the first place. Higher doses are not going to have better effects. If they can't take a statin, ezetimibe first line with the consideration of bempedoic acid. So there's only really 3 drugs in the prime prevention pathway for lipid management. Statin is the cornerstone. The addition of ezetimibe if they don't achieve the targets after dose titration, or the use of ezetimibe with or without bempedoic acid to get the 40% drop if they can't take a statin. Various links to the guideline, as I say, it's all aligned with NICE. One of the links is the statin intensity table. I'm pleased to say I did get the percentage reduction right with Atorva 20. So on the top you can see the statin dose, on the side the different statins, and Atorva's the 4th one down. So 10 milligram only gives a 37% drop, which isn't considered sufficient for prime prevention. 20, 40 and 80 obviously deliver more than the 40% threshold. With the rosuvastatin, 5 milligram doesn't give the 40% drop, but 10 milligram and 20 milligram are suitable options there. 40 milligram Rezuva is actually specialist use only. So although it's effective at lowering cholesterol, it also is associated with an increased risk of proteinuria. So it's not usually routinely recommended in primary care. And that's partly why NICE recommend Atorva. You can see across the dose range from 20 to 80, you get a much bigger impact with Atorva than you would with Rezuva in primary care, because you really shouldn't be going above 20 milligram routinely without specialist input. You can also see the impact of adding ezetimibe to a statin. It's actually better in some ways than doubling the dose of the statin in terms of cholesterol lowering effects. But obviously the evidence base for statins is, you know, huge. And ideally we prefer to titrate the statins first and then add the ezetimibe. If the patients can't tolerate higher doses of statins, then ezetimibe is a useful addition. So one of the things that we are challenged with regularly in primary care is persuading people, negotiating with people about whether they are or aren't willing to take a statin, partly because of the lay media. The Daily Mail loves to have a anti-statin story at least once every 3 months, if not more frequently. And that impacts on people. And it has to be said that the side effect profile of statins has been blown way out of proportion to the reality of the benefits versus the risk. So what we try to do to make conversations simple is look at the benefits. And this is based on a huge study of including over 170,000 people. It was a number of different studies combined. The benefits of 10,000 for every 10,000 people taking statins for 5 years, what does they deliver? And then in that same cohort, what side effects, significant side effects, would we expect to see? So if we look at the benefits first, for secondary prevention, so this isn't John's cohort, this is people with pre-existing CVD, we use a statin and get a 2 millimole drop in LDL, we would see 1,000 events avoided in that cohort of 10,000 people over 10 years, 5 years, sorry. And for primary prevention, people that don't have CVD, we would expect 500 fewer events in that cohort of 10,000 people. And in that same cohort, in terms of side effects, we really worry about myopathy, rhabdomyolysis. That we'd see 5 cases of myopathy in that 10,000 cohort, 5 to 10 additional hemorrhagic strokes, and the bigger one, 50 to 100 additional new cases of diabetes. And it appears that statins are sort of unmasking diabetes a few months earlier than patients who aren't on a statin. So that might help frame a conversation with your patient. And then we've also linked to other shared decision-making resources. So the British Heart Foundation have information for people, Heart UK, and a nice shared decision-making guide. So whichever tool you prefer to use when discussing with patients, you can link to any of those. Statin intolerance is a problem that we do see in general practice, not the overt, serious, life-threatening or life-changing side effects that I just talked about, the myopathies, the hemorrhagic strokes, and the diabetes, but there is evidence that patients will complain, particularly of muscle pain on statins. Interestingly, patients who have stopped statins because of muscle pain, if they're re-challenged blind, they can't identify when they're on a statin versus when they're on placebo. And I think we have to accept that as we age, we get more achy. I know I get backache. I'm not on a statin. If I was on a statin, I would probably blame the statin. So a lot of the association, I think, is a nocebo effect as opposed to a true effect. And there's lots of ways we can tackle intolerance. For primary prevention in particular, we can stop the statin for a few weeks and show the patient that the symptoms they're complaining aren't necessarily associated with the statin. We can restart a statin after that. Think about a lower dose. If they're on a Torva, you might need to move to Rezuva. It's water soluble. You get anecdotally less muscle pain with it, but it improves patients' confidence if you can say we're going to try a different thing. If people really can't tolerate a statin, then obviously we've got options now. We've got ezetimibe and bempedoic acid. They're not quite as effective as a statin, but certainly they are recommended by NICE. We would recommend statins first line where they can, and then moving to ezetimibe, bempedoic acid. The studies show the true rate of statin intolerance is around 10%. Some patients can tolerate lower doses of statin, which we would advocate, and then additional drugs if needed to get to target. People worry a lot about I can change my slides, it would help. The muscle symptoms and how we manage them, remembering that, you know, muscle symptoms can be caused by all sorts of things, and we need to have that in mind. But the most important thing with persistent muscle symptoms with statins is to check the CK. High levels might require the statin to be stopped, or will require the statin to be stopped, particularly where there's deteriorating renal function. But there is the option, if the renal function doesn't deteriorate further, to restart. But a lot of patients will have a normal CK. They've not got myositis. Statin isn't attacking their muscles. They've got a myalgia. They may accept stopping for a while. They may be able to tolerate the symptoms. They may need to stop for a while, and it's really just, and they may need to change. The other option is to change the agent if they're more happy with that. NICE did slightly change the CK recommendations in the last iteration, so we've updated that slide. Also, similarly with abnormal liver functions, it's a little bit easier. If the transaminases are raised, then we need to put in more regular monitoring, and hopefully they will resolve. Atorvastatin often causes a bump in the liver enzymes in the first 6 months and then settles. So just worth being aware of that. Doesn't require immediate cessation of therapy. So our patient John was primary prevention, but I thought it would be helpful to show you the secondary prevention cholesterol pathway as well, because there have been quite significant changes in that over the past few years. So NICE published a new guideline, I think it was December, and we updated our pathway in January around, and there were particular changes around secondary prevention. So, and we need to align the indicators with the new QOF and the new recommendations from NICE. So for secondary prevention, high dose, high intensity statin. So ideally going in with a Torva 80 or a Zuva 20. That should really happen mostly in the hospital setting if they've had a heart attack or a stroke. In primary care, we need to make sure they're achieving targets, and NICE have moved away from the 40% reduction and recommended that LDL cholesterol should be less than or equal to 2, and non-HDL cholesterol should be less than or equal to 2.6. Some labs report LDL, some report non-HDL. We're trying to get it consistent across the country at the moment nationally, but you should get one of the two, and therefore the patients need to achieve one of the two. The preference is LDL now, but a lot of places have moved to non-HDL, which is fine. Again, if they're not achieving targets, think about adherence and reinforcing lifestyle measures. Most patients will get to these targets on statins alone, but some will need intensification of therapy. And that could be ezetimibe, it could be inclisiran or the PCSK9 mAbs, which are mainly hospital-based. There's the same principle of statin intolerant to offer ezetimibe and then consider the other agents, which is bempedoic acid and the injectable agents for secondary prevention. And NICE have also said, even if patients achieve target, ezetimibe is cheap as chips. If you just add it into whatever statin dose they're on, there is still a benefit, and you could consider adding ezetimibe to everyone on a statin, even where the target's been achieved. The challenge with adding ezetimibe automatically is, so you have a patient who's on high dose, high intensity statin, a Torva 80, their non-HDL is 2.7. Sorry, their LDL is 2.7, so they're not a target. We're aiming for a target of 2. If you starting ezetimibe in that patient, you'll bring their cholesterol down, but you won't bring it to target. Ezetimibe only gives an extra 20% or so you might get to 2.3. They're still not met target. Now, they no longer qualify for inclisiran or PCSK9 mAbs. Well, they never did because the LDL wasn't that high. But, you know, now we've taken out the option for using inclisiran. So I think we have to be really careful where patients do qualify for inclisiran. Pretty much we should be preferring that to ezetimibe, because ezetimibe will never get any of those patients on its on top of a statin to target. I think that's quite a big shift in thinking for primary care, so just to be aware. And then there's a final new drug which we've added into the pathway because it's NICE approved for patients who have cardiovascular disease who have raised triglycerides. It's a drug called icosapent. It's a very fancy omega-3 fatty acid. But you only qualify for that if you're on statins and other, with or without other lipid-lowering therapies. Your fasting triglycerides need to be equal to or above 1.7, and your LDL needs to be between 1 and 2.6. So patients could qualify at different points in the pathway for this, because as you lower the LDL, they might suddenly qualify for icosapent. So it could come in at any point across that pathway. So links to the NICE guidance, as you can see, the statin intensity table, all of the drugs underlined in the resources link to their SPC, if I remember rightly. Or no, sorry, they link to the individual NICE technology appraisal. And there's 2 for the PCSK9 IMABs. So hopefully that clarifies and simplifies to a certain degree lipid management, because I think it has got very complex. But, you know, we have a great opportunity to reduce cardiovascular events by optimizing these patients with established cardiovascular disease in terms of achieving those cholesterol targets that NICE have concluded are clinically and cost effective. Lots of new drugs. Well, lots of drugs generally, lots of newer ones that you may be less familiar with. So we've compiled a table of where the drugs can be used, how they're given, you know, oral or injection, what LDL lowering they deliver, what outcomes data they have, and what safety data they have, because that'll help you have that conversation with patients about the use of these products. And sitting behind that, we have information sheet on each of them. So one on inclisiran, where it's approved by NICE, how it works, etc. Bempedoic acid, which is only approved by NICE for statin intolerance in combination with ezetimibe, although many local committees have said it can also be used as monotherapy where people can't tolerate ezetimibe. And one for this new one that I just talked about, icosapent ethyl in second prevention. So huge amounts of resources on our system. I'd encourage you to have a look around. Lots of resources for patients as well as for clinicians. And I'm going to hand back now to Harry, I think. Thanks for listening.
Brilliant. Thank you very much, Helen, for taking us through that. Does anyone have any questions at all on any of those bits, any of the resources specifically, or sort of more generally? Nigel?
Yeah, thank you. I mean, that's absolutely brilliant and really, really welcome as a summary of where we should be going. Just one comment. You mentioned checking compliance as the clinician after a lot of workup by others. I would suggest as unpublished work, we've been doing a lot of work with diabetes and MDT design. And a lot of it is predicated on uncontrolled diabetes levels with HbA1cs. And we've now moved the first response sort of contact with the patient, which might be with non-medics, but support people like health wellbeing coaches or social prescribers, as being to check compliance. And compliance, phobias about medication, phobias about the illness, what they don't understand about it. I would advocate should be put right at the beginning on that first workup. Lifestyle, one of the things which should emerge is that we're in a very deprived area. A lot of people work night shifts, variable shifts. They find taking medications difficult. They do it at the same time every day. Do they do it at wake time, rota for that week? And they need that sort of help and support. And certainly on the diabetes, we actually get very few people going to the full MDT because so many of them, the workup, and fit into categories with compliance, lifestyle modification, answering their anxieties about their illness, what it means to them, which you do address, but at that stage, and the fear of being on multiple medications, which I guess is where we end up on this pathway, and having their lives taken over by side effects, which is a real fear, and is the balance we've got to provide between the numbers and the person. But thank you, really great summary. Thank you.
Yeah, I think we had long discussions about where to really focus the adherence conversations. We could, in the pack, it talks about asking about how often they forget their medicines and that sort of thing. What we were sort of encouraged to think about is, could that individual, they could identify there was an issue with adherence, but often weren't then able to cope with, you know, addressing side effects or complexities of the medicine. So I think there's probably a bit of a split role, and it also depends on the competency and confidence of the person who's doing those initial consultations. I think there's no reason why people can't be trained up to do that. A lot of the time we're using HCAs in the early days, and that there was concerns about how comfortable they were having those deep conversations about medicines and medicines adherence. But I think it's really important the conversation happens. I'm not sure it matters where, as long as it's a good, you know, informed conversation for the patient. Pete, do you want to say? I think it's mainly more Steph was involved in those early conversations about where do we tackle adherence to medicines.
Yeah, no, thanks, Helen. So I think when we developed the slides, it was really absolutely we thought quite hard about where we put this, and I think it just reflects the kind of the different approaches that different practices have taken, different PCNs have taken, and often, you know, there may be an initial desktop review by someone who's competent to look at this and whether they're taking it. So I agree. I think the most important thing is actually having that conversation and making sure you're actually looking at and seeing that the patient's picking the prescriptions up, and making sure you're competent enough to have that conversation. There is, I think, some resource available in terms of the slide packs and the proactive care guides, which go into that in a bit more detail.
Brilliant, thank you. Are there any other questions at all? Feel free to just pop it in the chat, or maybe put your hand up.
Just to comment as well, really on that we don't see these as sort of blueprints that are fixed in stone, and you know, all of this stuff can be flexed locally. This is a sort of a starting point, and every workforce in every practice seems to be quite different as well, and what people are already trained in and need additional support for. We have got training needs assessment on the website as well, and some suggested areas you know, that people can use for self-development around the packs for different types of groups of staff, because there's some, obviously you'd expect the pharmacist to know quite a lot about the medicines, but maybe less about the lifestyle, for example.
Brilliant, thanks, Helen. Yeah, I guess so to summarize, hopefully you did find that helpful, and it was a useful run through of what we have available and how you might deploy those throughout the sort of patient journey. The slide packs are available, as I said, through the dashboard, and we saw at the beginning. They're also available on our NHS Futures page, so if you want to sort of share them with the sort of wider workforce who aren't regularly accessing the dashboard, then you can join our Futures page, and they're all available there. We also have the wider proactive care framework resources that Helen was mentioning, so things like the workforce optimization guides and the competency frameworks that might be useful to sort of do that initial stock taking piece that I think is quite vital. So all of that's available on the UCL Partners website, on our microsite specifically for the proactive care frameworks. So perhaps after this email with the recording, after this meeting with the recording, I can send an email with the link to that page as well. Yeah, please do take some time to have a look through these resources. They've been developed with you in mind, and making as easy as possible to have quick access to this information. And as Helen said, it's all designed to be locally adapted and implemented, so you can take bits and embed it locally in pathways and resources that you might already have. If you do have any questions after this session specifically about the resources, feel free to email me or get in touch with our generic CVDACTION email, and myself or another colleague will be able to set up some time with you to talk through those in more detail. Brilliant. So if there's nothing else, then we'll end there, and thank you everyone for coming along, and big thanks to Helen and Deep for your time. Thank you. Bye.